All right, so we're going to get going with class number 2 here. This is going to be now EKG interpretation. So we already went over some of the basics, some of the components, things we need to know. Now, how can we actually apply that and actually start interpreting EKGs? So let's go over some of our objectives for this class. So we want to find an organized method to interpret EKGs, whatever that method is for you. Maybe you want to look at it a certain way, or there's just a better way you think of looking at these. That's great. This is just going to be an option for us. We're going to do some practice EKG interpretation again. We're going to keep that really short and simple, not to get too deep into some of those subcategories, but we'll definitely look at getting a little bit of practice in. Also, we're going to talk about what our EKG interpretation is actually going to do for our patient, why we should be looking at this, and then we'll go over heart blocks and what those look like, how can we identify them. So first off, we want to be able to understand time when we're looking at our EKG strip. So we know that um, us using the Zols and the Philips monitors, we have actually two different types of rolls of paper that we use. Some of them already have the printed EKG boxes on them. We know that there's big boxes, little boxes, where our Zols actually, it just uses a plain white paper and it prints out the boxes for itself. It uses the little dots there. We'll pull some of those up as well. So what do those actually mean? Well, let's look at the big boxes. The big boxes represent zero point 0.2 seconds of time. So 0.2 seconds of time is represented by one big box, and within that big box, that large square, we have five uh, smaller boxes, and those represent 0.04 seconds of time. So we know that obviously 0.04 times 5 is going to be zero point 0.2. So if we have five of these 0.2 seconds or five big boxes, that's going to represent 1 second of time, right? If we have 15 large boxes, that's going to represent 3 seconds of time. So again, just kind of being able to interpret what those boxes actually mean. And then another thing we'll see on our paper when it prints out of the monitor, it should read 25 millimeter per second feed, and that just tells us that as the EKG waves are being printed onto the paper, it's being represented accurately in time in reference to these boxes because it's printing at a specific rate. So that's why those are key things that we want to understand when we're looking at our EKG papers, EKG strips. All right, so where would we start? Well, a good place to start is usually by analyzing the rate. So, what are our normal parameters? Well, as we mentioned actually in our previous class, we know that a normal rate is considered somewhere between 60 to 100, somewhere between 50 to 100 for some patients, 60 to 120 for others, right? But really, we're sticking within that 60 to 100 rate. So what is the rate? Well, how are we going to be able to identify that? Let me back up just a second. So we want to identify, is it normal, is it tachycardic, or is it bradycardic? So what is the rate? So are we between 60 to 100? Is that normal, right? Are we above that 100 range, in which case would be tachycardic? Or are we less than 60? Is that bradycardic, right? Uh, Now, does that necessarily mean that it's abnormal for that patient? No, not necessarily, right? Depending on this situation, obviously. So when we're analyzing the rate, what we want to determine is this normal tachy or brady, right? Tachycardic or bradycardic. There's a few different methods that we can use. So one of those methods being the box method or the R to R method, and we'll pull up another little uh, preview of this so that you guys can get a good look at it. Let me pull that up here. All right, cool. So we have the box method, we have a 6-second strip method, The monitor is obviously going to be throwing a number out there at us. We have our SpO2, which just with that light, it can count the pulses, right? The pulsations that come to the fingertip, or we can manually sit there for whatever length of time you feel necessary to count those beats, and we're just basically palpating a pulse, right? Those are all different methods that we can use to analyze a patient's pulse rate. So let's look at one of those, the 6 second strip method. So when we're looking at a 6 second strip, which is actually what we're representing here on the monitor. So if you look at the center, just past that third QRS complex that we can now identify, right? Right after that third QRS complex, there's some black little dots right in the middle of the screen. Let's just make sure we can identify our 3 second marks here. So specifically, this is actually from our Zoll paper. So we can see this right here. Let's circle that a few times. So this line right here, this dark line, it's usually these black markers on the Zoll paper. That represents our 3 second marker. So we also have another one right over here. So this line right here, it's got some black dots. I'll point to it right there, right there, right there. So those are our 3 second markers. So from here to here, right, we have 2 QRS complexes in between. That's 3 seconds. And then we go from this mark, our 3 second marker, to this mark right over here at the end of the right side of our screen. That's our next 3 second marker. So overall, we have 1, 2, 3, 1, 2, 3. Those are 6 seconds. Sorry. So those are six. This is a 6 second strip. So what we can do when we're trying to identify, just take a quick look at the strip, is we can identify we have 1, 2, 3, 4. So we have 4 QRS complexes in between these 6 seconds, right? In between these 3 second markers. So what we can see is that if we multiply that by 10, well, we know that our rate is slow because 10 times 4 is 40, and that's actually what our heart rate equates to here. So that's a simple 6 second strip method. We just take however many beats there are in that 6 second strip, multiply it by 10, and that gives us the heart rate, as you can see at the bottom of your screen there. Cool. The R to R method, or the box method. So this was the first method that we mentioned in our previous slide. So what we do is that when we're looking at our large boxes, and I mark them out here for you so they're a little bit easier to see, is that if there is a QRS complex that lands right on the line of one box, and I were to calculate that to the next box, well, if there was another QRS complex that comes right up, that's going to equate to 300 beats per minute. In this case, we can see that we're about 2 whole boxes apart from one QRS complex to the next. Now, we know that that's fast, but as you can see at the bottom of your screen, if it's from one box to the next, that equates to 300 beats per minute. If we're 2 boxes apart, that's 150 beats per minute, and we can keep on going down the line. If we're 3 boxes apart, we're at 100. Next one is 75, and the last one is 60. So in this case, and I know we see the number right at the top right of our screen there, but let's go R to R. So let's identify which one of these boxes would be easiest to look at. So let's go right around here. So if we go to this box, that one almost lands on the line, and then we come right over here, and we know that there should be a line right around here, but this QRS complex comes right before it. Well, had it landed right here, that we would be right at 300 beats per minute. but it's closer to that second box at the 150 range, right? So if we're 2 boxes apart, it would be at 150. So we know that it's somewhere between 150 and 300. But if we look right up here, it's giving us 160, which is about right. We're about 2 boxes apart here. We can kind of see that these are about 2 boxes apart. So yeah, we're going to call that 160. 150 would be fairly accurate as well, but we can see our computer over here telling us it's 163 was our accurate heart rate. So again, this is just another method, the R to R method, that works just as well when we're looking at rhythms like this. Specifically, faster rhythms works just fine. So again, just identifying those two R to R points that we're going to be calculating our rate with. All right, so after we analyze our rate, we want to look at our rhythm. So what is the rhythm, and how can we identify it? Well, is this a regular rhythm? Is it occasionally irregular? Every once in a while, we're kind of feeling it, and we see an extra beat in there, or we realize that, that didn't rhythmically come rhythmically like the rest of the beats did, right? Is it regularly irregular? Can we palpate the pulse or look at the EKG strip and say, that's odd, every three beats I'm feeling an extra beat, or every 3 beats I miss a beat and then it picks right back up, something like that? Or is it irregularly irregular? Is it just kind of random? Can't really put a rhythm to it. When we're trying to calculate the rate, we just have to sit there, palpating a pulse. So again, those are things that we're going to be looking at. Is it regular? Well, that generally tells us that everything's looking good. Is it irregularly irregular? This is how we would identify something like AFib, right? AFib is irregularly irregular. So just something to be able to give it a name to the rhythm. Next, we want to assess our P wave. So we looked at our rate, we looked at our rhythm, and then we want to look at our P waves. Now, if we remember from our previous class, P waves tells us that it's originating at the SA node within the atria, and then the impulse, that electrical impulse, is moving correctly down through the heart, right? So, do we have P waves? Are they present? Are they regular? Do they look appropriate, right? Just a small little hump right before every QRS. Are they coming before every QRS, right? If we can identify a QRS complex that doesn't have a P wave, hey, that might be something to point out. Are they present and upright? Uh, just a kind of an interesting point here that we didn't get into in our previous class is that when our P waves are upright, it means that they're coming from the right spot within the heart, from that SA node. If they're not upright, if they're inverted and they're really close to the QRS complex, well, that might be because they're coming from a lower part within the atrias and they're actually moving backwards because they have to let the rest of the atria know, hey, you guys need to depolarize because it didn't come from the right spot. So that's what this EKG interpretation is allowing us to do. All right, cool. So let's look at this strip here. So let's identify some P waves. Can we see P waves here? They're a little bit harder to identify, but what we can see is that right up in here, we have a small little P wave. Comes before every QRS complex, right? QRS, QRS, QRS. So we see P waves, we have a QRS complex. We see that it seems a little bit fast, right? Because we just have a really regular rhythm that's traveling through here. So what is it? What is it that we're seeing? So if I were to use, let's say the box method or the R to R, I'm going to move down to this middle strip right here, and I'm going to come right here because this one lands right on a line. So if I go to one line, that's going to be 300. I go to my next box, that'd be 150, right? If I went to my next box, that would be 100. So it's somewhere between 100 and 150. So let's split the difference. Let's call it 125, right? So if I'm going R to R or using this box method, I can identify this rate as being somewhere between, somewhere about 120. We have a heart rate of 125, right? Or that's what we're splitting the difference at because our next R wave lands right in the middle of a box. But that's exactly what we had. We had a 54-year-old female, uh, acute onset nausea vomiting, and what do you know? Heart rate is 120. So let's look at uh, our next parameter. So our PR interval. So our PR interval is important to look at as well. It can tell us a little bit more information. So our PR interval starts, as you can see in your screen, at the beginning of the P wave and stops at where the Q wave would be. So what's considered normal? Well, anything less than 0.2 seconds is going to be normal. Now, if we remember from the beginning of this class now, 0.2 seconds is how many boxes? 5 small boxes, right? 5 small boxes or 1 big box, that's 0.2 seconds. So anything less than that is normal. We just don't want it to be right up against the QRS complex. So again, just something like this, 0.16, perfect. We can move on. Take a look at this EKG strip here. So what can we identify? Well, let's start looking at what our underlying rhythm is. We see some really ugly waves there, but let's identify those that we can, right? So if we look right in the center of the screen, we have good P waves. We have what look like to be appropriate QRS complexes, right? And when we look at just that part of the rhythm, the rate seems to be appropriate, right? If we use the R to R method, we have, let's see, 300, 150, 175. So we're right around 75 on the rhythm. But if you look at the top, the computer was actually identifying this rhythm as 54. Now, is that necessarily accurate? It's actually not. So what the computer did is the computer does use the R to R method, but in this case, what the computer did is it takes the R to R method running from the top of the, let me get my pointer out here. So it took the top of this QRS complex. So it took this R wave to this R wave, and we can see that that's a much bigger gap there than if we were to go from this R wave to this R wave, or from this one to this one, because we can see that the rate is within a normal range, right? So again, not getting caught up with what the computer necessarily tells us or spits out at us right away, right? We look at that underlying rhythm. The rate is where it needs to be. We have P waves. We have a P wave for every QRS complex. The rhythm seems fairly regular, except for these big ugly things that are popping out at us, right? And that's what we would identify as a PVC, or a premature ventricular complex. And they pretty generally look just like that, big and ugly, and they just kind of obscure the rhythm that we're looking at. But our underlying rhythm in this case, and when we're trying to identify that PR interval, what are we looking at? Well, it looks good. It looks like it's within its appropriate range. So the QRS complexes. Now, let's analyze those QRS complexes. So do they all look alike? As you saw in that previous slide, right, we sometimes get some that look really big, really ugly, can be readily identified as well. No, that does not look like the rest of them. So our QRS complex, we want it to be somewhere between 0.08 and 0.12 seconds. How many small boxes is that? Well, if we remember, one small box is 0.04 seconds, right? So somewhere between 2 boxes wide and 3 boxes wide would put it within this range. And it's a fairly small range, but the QRS complexes can be narrow like that. Now, a widened QRS complex is usually going to indicate that there's some kind of bundle branch block, and we need to investigate it a little bit further. In our first class, first CE day that we had, actually, it was brought up as to, well, what's actually going on? What are we seeing when QRS complex um, is really wide and ugly like that? And I like to keep things simple. EKGs can get very cumbersome, very confusing, very fast. But if we remember that picture of the heart and the electricity moving through it, imagine that your uh, bundle branches after they hit after the AV node, it comes to the bundle of his, and then it splits in two, right? The right and the left bundle branches. Imagine that it can't come down through its regular pathway through the septum. Well, now it has to find a course that's wider or away from its normal course to get back down to the rest of the ventricles. So that's how I imagine it is just taking a detour, and it has to go around possibly an area of the heart that just the electricity is not moving through correctly. Could be a previous problem, but that's why we end up with these really wide QRS complexes, or what we would identify as a bundle branch block. And depending on other things, we would need to look at a 12 lead to know whether it's coming from the left or the right. But that's just a little bit extra information for us to know. Cool. So we take a look at this QRS complex. Now, we have three on the right that, well, those look alike. But then we get these two big ugly things on the left side. Um, Now we can see that they're very, very wide, right? Because if we go from the beginning, let me point that out. If we go from the beginning of this QRS complex here to where it comes back to baseline here, well, that's really wide. That's almost 2 boxes wide. That's not right. But the rest of them seem like they're doing okay, right? This QRS complex looks like this one looks like this one. So we identify these as just premature ventricular complexes. Again, just something to point out. Sometimes they can be corrected. In general, they're not something we really bother with. They sometimes tend to rectify themselves. But at the end of the day, what are we really worried about? Well, we really want to take a good look at our patient. Does he look like this? Because if that's the case, we got bigger issues, right? So we look at our EKG findings. Do these correlate with what our patient is feeling? Are they symptomatic? Do they have any kind of altered level of consciousness? Are they showing hypoperfusion? Is their blood pressure low? Are they experiencing any kind of chest pain, back pain, shortness of breath, abdominal pain, nausea, vomiting? Right? All these things are just things we want to uh, be able to identify, because again, we're treating our patient. We're not treating our numbers. We're not treating our what the monitor is trying to tell us. Let's get into some of these. Make sure I didn't miss anything here. Let's get into some of the rhythms that we should be able to readily identify. And so let's take a look at this very first one. So what does this look like? Well, it looks like an unorganized, chaotic rhythm, right? And this is what we would identify as ventricular fibrillation, or VFib. Now, one thing that we need to know about this is that if we see this, we need to know that that can be shocked, right? This is a shockable rhythm. It's something that can make a big difference if we get to it early on. So VFib, we should be able to readily identify this and know that it is a shockable rhythm. Our next shockable rhythm as well is going to be ventricular tachycardia. And it has this very typical look to it. So remember when we were identifying uh, our QRS complexes, well, let's just take a look at this. What it's telling us is that the ventricles are beating super fast. That's why we have this very wide electrical movement. It's a very wide complex tachycardia. So again, all we're looking at here is QRS complexes that are really, really fast. And that's why we see this. And again, this can be rectified by shocking the patient. And again, we're going to be looking at them. Maybe they're unconscious, but they're showing this rhythm. Well, that needs to be addressed right away. Our next rhythm is asystole, or what is known as a flat line in modern TV days, right? Is this a shockable rhythm? No. Unfortunately, we see that pretty frequently on TV, but we know very well that asystole is not a shockable rhythm. In this case, we would just do something like continue CPR if it's something that we're already working, right? Or, whatever other considerations we need to take there. All right, let's take a look at our heart blocks then. So these are the ones we'll be looking at: a first degree block, a second degree type 1, a second degree type 2, and a third degree. So this is what's known as a heart block poem. You can find it online. I personally really benefited from this, being able to break it down this way, because it just helps my brain wrap around EKGs basically. So a first degree block. Let's go over these poems. So first degree: if R is far from P, then you have a first degree. Remember, we were talking about that PR interval earlier in this class specifically. Well, that's exactly what we're identifying. If we're further away than that 0.2 seconds than one big box, what it tells us is that we have a first degree block. Is that necessarily dangerous to the patient? Not necessarily. They're not going to die immediately from it. And for the most part, it's usually just kind of watched. And a lot of times patients might know that they have it, they may not. So we may be able to identify that. Second degree: longer, longer, longer drop. Then you have a Wenke block. So a second degree block type 1, also known as a Wenke block. That's how we can identify it. So we have a prolonging PR interval, and that's why it says longer, longer, longer drop. So that PR interval prolongs so far that it drops a beat, and then we miss a QRS complex completely until the heart resets and starts over. And we'll take a look at some pictures of these. Second degree type 2: if some P's don't get through, then you have a Mobitz 2. So this is a second degree type 2. So we may have a P wave, but after that P wave, it was not immediately followed by a QRS complex. That may indicate that there's a second degree type 2 block going on. And again, that's something that needs to be pointed out. A third degree block: if P's and Q's don't agree, then you have a third degree. So this one's a little bit easier to, once we look at the picture, you'll be able to see that the P's are kind of doing their own thing. That would identify the atrias, right? The atrias are doing their own thing, and the ventricles are beating at their own rhythm as well. So they're not necessarily talking to each other. The top part of the heart is not talking to the bottom of the heart. So that's what we would identify as a third degree. So let's take a look at these. First degree: if R is far from P, then you have a first degree. So what it's identifying is that this PR interval right here, is getting further away from this QRS complex. And first degree, like I said, is usually pretty normal. It's not something that we're going to be super concerned with. There's really not much to do about it. They're generally benign, and they're generally asymptomatic as well. A second degree type 1, or a Wenke block. Let's look at our poem. Longer, longer, longer drop, then you have a Wenke block. So let's point those out. So we looked at our PR interval here is longer than our PR interval here. So it got longer, longer, until it dropped, and then the heart had to reset somewhere in here to send that P wave, right? The SA node had to fire off to get the heart reset again. But as we can see here, that PR interval seems to lengthen again, which it probably just follows this rhythm of dropping a beat somewhere after that. So that's what we would identify as a second degree type 1, or a Wenke block. Can be symptomatic at times. Again, we want to look at our patient and see what the patient is actually presenting with, or what the patient is experiencing. A second degree type 2, or a Mobitz 2. Let's look at our poem. It says, if some P's don't get through, then you have a Mobitz 2. So in comparison with our second degree type 1, we don't see that lengthening of the PR interval here. So here we have appropriate PR interval. Same goes on here, here, and here. But we see that this little P wave here is missing its buddy. It's missing that QRS complex, right? So if it's missing a QRS complex, same thing going on here. That's telling us that some P's aren't getting through to the ventricles, indicating that second degree type 2 block. And then we'll take a look at our third degree. So our third degree block, if P's and Q's don't agree, then you have a third degree. So what does that tell us? Well, it tells us that our P waves, so we have a P wave here, we can see one here, here, here. There's probably one buried in here somewhere. From here to here, from here to here, we can see that these actually follow a pretty regular rhythm, right? Whereas when we look at our QRS complexes, it's not necessarily talking to this QRS complex. This isn't a super long first degree. This means that there's just no correlation going on between the P waves and the QRS complexes. So the QRS complexes are beating at their own slow rate, as you can see there, and that uncoordinated beating of the hearts, the top part, not the atria, is not talking to the ventricles, tells us that this patient is experiencing a third degree block. Cool. So just so you guys know, I mean, we've really only scratched the surface with this EKG interpretation practice that we had. And really, there's a lot more to it. We just wanted to keep it as practical as possible for everybody. If we see something, we want to be able to identify it. And be able to say, hey, we need a higher level provider, we need a paramedic, we need somebody else to come identify this. Maybe this patient needs to go to a specialty facility. But same rules apply here. If this still does not allow the non-paramedic provider to interpret EKGs, 4 leads or 12 leads, right? We still can't write this into our narrative. Rather, we want everybody, whether that be EMT, advanced EMTs, to be able to cue in when we see this kind of discrepancy in our EKGs, and be able to call ahead or alert a facility of what's going on with this patient. So your documentation should still indicate interpreted by computer, indicating this finding. We don't want to cause any kind of liability issues if we were to put our own name behind that interpretation, and we're not necessarily allowed to in this state. We also want to remember that EKG placement and transmission, however, to a facility is still a basic skill, just not interpretation. So remember that at the basic and intermediate levels, absolutely, placing an EKG, placing a 12 lead is still a basic skill and an intermediate skill. It's not just a paramedic skill. And that can be sent over to whatever facility it is you're taking that patient to, and maybe even let that doctor make that determination. So I hope this class was helpful to everybody, and I hope you're all having a great time watching these videos. Again, if any questions arise, please feel free to contact me, and we will see you all soon.